Hello, my name is Jenny Jones, and on behalf of the Johnson & Johnson Institute and Ethicon Professional Education, we are excited to have each of you here with us today. Johnson & Johnson and Ethicon are highly committed to the bariatric space and providing educational training opportunities to help each of your practices enhance and optimize patient outcomes. Today's webinar is a dietitian's role with modified duodenal switch. We have Sharon Zarabi as our faculty for today. Sharon is a registered dietitian, certified dietitian nutritionist, and certified personal fitness trainer with the International Fitness Professionals Association and Aerobics and Fitness Association of America. Sharon co-authored Nutrition for Opera Singers, acts as a contributing writer for a medical magazine for the Bariatric Times, serves as an expert presenter for Bari MD, has been quoted in Time Out New York, and currently lectures extensively on weight management and wellness at various community centers throughout the New York area. As nutrition coordinator of Lenox Hill Hospital, she runs the monthly support groups for both postoperative and preoperative patients and served as 2007 to 2011 Walk from Obesity leader. Sharon also serves as a private counselor for weight loss surgery patients of Lenox Hill Hospital of New York. I'm going to turn the call over to Sharon, where she'll go through her presentation, and then we'll have a Q&A session at the end. So again, thank you for joining on behalf of Johnson & Johnson and Ethicon, and over to you, Sharon.
Thank you, Jen, for the warm welcome. I'd like to thank you all for participating in the webinar today, and I hope that you'll gain some insight on the modified duodenal switch. I've been a bariatric dietitian for 10 years now, and I've seen a lot of the trends when I first started with the lap band being a popular mode of surgery, and we still have the Roux-en-Y gastric bypass as the gold standard. And we started doing the gastric sleeve about 8 years ago, and within the past 3 years, we've seen a little bit more with the duodenal switch. So I'd like to share a lot of the research that we found at our program. Okay, so I am working on behalf of Ethicon and J&J for this presentation. And a few of the objectives that I'll be reviewing today are understanding the surgery and how it leads to weight loss, becoming a little bit more familiar on the latest research that we found at Lenox Hill Hospital with the modified duodenal switch, to review a few of the nutritional concerns, how to prevent and treat these issues, and of course, some suggestions and tips for long-term success. I would like to take a lot of what I've learned as a personal trainer to go over, again, weight management and long-term weight loss. So I'm not sure exactly how many dietitians we have on the call versus allied health professionals, but I do know that I speak for many dietitians when I say that we are not just people who are recommending food plans, but we become more of life coaches, food therapists, and of course, support group leaders. I know that we at our program in New York City have support groups that we've actually started to call healthy living courses, only because I had a few patients who felt that support group gave a little bit more of a negative connotation. And by, again, changing our title to healthy living classes, our patients are able to engage both, preoperatively, postoperatively, and even we have long-term veterans who are about 12 years out. And by having all of our patients in these group settings, they're able to feed off of each other's energy, of the experiences that they have even long-term out of surgery. So again, our role as dietitians are more than just in the office, but definitely outside. What we do, again, preoperatively, is we assess the patient's nutrition knowledge and go over a little bit of their weight loss history. A lot of them have tried some crazy diets, from the cookie diet to the grapefruit diet to the cabbage soup diet. So I've heard, a lot of desperation and almost food starvation diets for our patients who are looking to lose weight, and then they come to us to pursue surgery. So it's important for us to, again, go over their history and again, manage the balance between their nutritional integrity and losing weight in a healthy manner. What I try to do is have our patients become loyal eaters. And what I mean by that is having them honor their hunger. I think a lot of them, when they're trying to lose weight, think that, again, starving themselves and walking around hungry all day is going to help them achieve their goals. So again, we want to teach them the importance of a balanced diet. Again, upon our initial assessment, we counsel our patients through lifestyle changes. We want them to comply with the proper eating patterns. And obviously, some of our patients can be stress eaters, so we do want to teach them some stress management skills, how to keep the weight off for good. If we have any smokers, how to stop smoking before surgery and to avoid any grazing habits. Because sometimes we do see some patients, when they stop smoking, they may gravitate to foods and snacks. So, and of course, a lot of my talk at the end will be about fitness and exercise, because we won't see weight loss, again, just with what we eat, but a lot of it has to do with keeping our metabolism going, which is affected through our fitness and exercise routine. So I don't know how many of you are familiar with this diagram, but this image is basically what the modified duodenal switch is. And as you can see over here is where the greater curvature of the stomach is, and that portion of the stomach is removed. And what we do is we create the first stage, which is the gastric sleeve. The pylorus is still intact. And the modified duodenal switch, which originally Dr. Roslin, who is the surgeon that I've been working with, termed SIPS, stands for Stomach Intestinal Pylorus Sparing Surgery. Okay, so that's the SIPS. Again, because insurance has not been approving the surgery, we've been using some modified codes for insurance approval. It is still under an investigational procedure. So we've coined the term modified duodenal switch as opposed to the classic duodenal switch. And what you can see here is, again, it's looped up. So what we do is we measure the short bowel about 3 meters from the colon. And then where you see part C is where we loop it up back to the pylorus. So basically, we're creating a longer common channel. And then the digestive juices are going through this channel over here and then mix with the food right where the A meets the C. So what we hope for is that our patients feel less hungry, again, because of the restriction that we see with the gastric sleeve. That's also going to be causing them to feel full soon after eating. They're going to be absorbing fewer calories from the foods they eat because of the malabsorptive component. And they're losing most of their excess weight within the first year. And I'll be showing some charts that show the trends of weight loss during the time frame. They're going to be keeping the weight off over the long term. And of course, we've seen significant health improvements. And I'll go over that with some of the research that we've shown. As with most bariatric procedures, we do see some common complications with the modified duodenal switch. Some of them include anemia, metabolic bone disease, thiamine deficiency, B12 deficiency, hair loss, weight regain, increased gas, nausea, vomiting, and some protein deficiency. So the following slides that I'll be going over, we'll be reviewing how we've handled this at Lenox Hill Hospital. Again, another diagram that I've put together to have you better understand a little bit about what's going on and why we supplement with specific nutrients. So what you see here, again, with this thin, narrow, tubular structure that the gastric sleeve is created, is where a lot of the water, copper, iodide, fluoride, and molybdenum are absorbed. And molybdenum actually helps with protein absorption and the breakdown of amino acids. So these are actually compromised due to this part of the surgery. You'll also notice a lot of the fat-soluble vitamins A, D, and K, excuse me, are also affected. So again, we might need to supplement with that. A lot of the bile salts and your B vitamins will be affected as well. So this diagram shows where a lot of the nutrient absorption sites are and how they can be compromised with any malabsorptive procedure. So as I mentioned, I became a bariatric dietitian back in 2006, and at that time, it was called the ASBS. It was American Society of Bariatric Surgery. It was a very, very small group of dietitians who were participating in the conferences at that time. And again, no nutritional guidelines. So, you know, I think most dietitians were just doing what they were told by either their surgeons or what our background was in weight management. And it wasn't until 2007 where they changed the name to ASMBS and they added the M to include the metabolic portion. And we came out with some guidelines in 2008 and again, nutrition standards of supplementation and how to assess patients preoperatively and postoperatively. And exactly in January of 2017, there's a more upgraded guideline. So this actually came out a month ago. It is the ASMBS's Integrated Health Nutritional Guidelines for the Surgical Weight Loss Patient. I do suggest that all of you have this handy in your offices, as well as another resource that I usually tend to cross-reference when I'm going over any deficiencies for my patients, which is the Micronutrition for Weight Loss Surgery Patients by Jacqueline Jack. So these are two great resources. If you don't have, I highly suggest, because a lot of what I'm going to be going over in the next couple of slides are referenced from these sources. So now on to the fun stuff. Here we have a study that we presented at the IFSO conference back in Brazil in September, and it's going to be followed by another research study with a little bit more detail with a poster that we presented at ASMBS at Obesity Week in November. And I have to give a lot of credit to our research assistant, Sarah, who's helped gather a lot of the data that I'll be going over because, again, we've only been doing the duodenal switch for 3 years now. And a lot of the data that you see here is coming from Dr. Roslin's office, again, at Lenox Hill Hospital in New York City, as well as his other site in northern Westchester. So what we did, I know the font is very, very small, but we did take about 152 patients who had the modified duodenal switch. About 70% of those patients are primary cases of the MDS. 20% of them are bands converted to the modified duodenal switch. 10% are gastric sleeves to modified duodenal switch. And what we found between the years of 2013 to 2016 is that their lipid profile and their glucose regulation were significantly improved. And again, what was thought that they may be compromised with any nutrient deficiencies, which I'll review in the next chart, was actually proven to improve with time. So if we go to the next slide, what you see here is I've drawn an arrow. What we saw here was preoperatively patients were at 58.2 with vitamin A, and over time, within the first 5 months, it decreased. Now, what happens at our program, again, being in a busy clinic in New York City, is that a lot of our patients come in for their pre-op education and they have gotten information overload. Being that we're a comprehensive program and MISQIP accredited or MBSAQIP accredited, our patients come in, they meet with myself, the dietitian, they participate in a nutrition class, they meet with a psychologist, they meet with the surgeon, and they have to have all this pre-op workup done. And it could be months before they go for surgery from their first pre-op visit. So a lot of the information that we give them on dietary compliance can be lost in translation over time, or they may have forgotten. So the vitamin protocol is something that we need to review with them on their first post-op visit. So you can see here that, again, within the first 5 months, there's a slight decrease in vitamin A, and then with time, it actually improves. And basically what we attribute this to is, again, when they come in for their first follow-up visit, we are actually going over their vitamin regimen, and with time, we see improvements. Vitamin D, again, same thing. It starts off at 24, and with time, it actually improves. We do see a lot of deficiencies preoperatively as well, so I can't attribute any of these nutritional concerns to surgery. So again, what we found over time is that with the improvements that we've seen in hemoglobin, hematocrit, iron, glucose, hemoglobin A1C, albumin, thiamine levels, B12, cholesterol, HDL, LDL, and triglycerides are all actually improving with time. And this suggests that the 3-meter common channel does not influence or affect vitamin absorption. Okay, and then what we see here on the next slide is a graph representing, again, the changes with time. So the dark green represents pre-op levels. I guess that would be more of a turquoise, is about 1 to 5 months. The blue represents 6 to 12 months, and the maroon is greater than 12 months. And again, what you can see here is that there's improvements in B12 over time. There's also improvements in iron with time, as well, as you can see over here. And then again, the vitamin A can be compromised due to maybe, again, low levels of protein or prealbumin levels, which I will be going over in the next couple of slides. So again, keep in mind that vitamin A may be low due to the relationship between vitamin A and protein metabolism. So in the next few slides, I will be going over some of the recommendations of prophylactic treatment and how to treat any deficiencies with the modified duodenal switch. Here we have a table, and this basically represents a more updated look at weight loss over time. We have taken data from 3 different surgeons at 4 different sites. We have, again, Dr. Roslin, which represents Lenox Hill and Northern Westchester here in New York, Dr. Cottom, who is in Utah, and Dr. Enoch at North Carolina. And what you see is the outcomes of weight loss over a 3-year period. Most of the weight loss actually occurs within the first 2 years. So again, I've highlighted the 85% here. As you can see, that's the most weight that they've lost, and then it goes down to 81% because the patients are actually plateauing at one point. As what you can also see is that the estimated weight loss percentage is most or greatest within the first 6-month period. So basically, our patients are losing a lot of their weight within the first 6 months of surgery. Again, I think a lot of the fear is that with the modified duodenal switch, with this excess weight loss comes with nutritional implications. But what I'd like to say is that with my experience, and again, I can only really speak for myself, we've seen that there's a slight advantage with the bypass over the sleeve in regards to weight loss. And the classic duodenal switch has the highest weight loss and what we've seen with lowest recidivism. And the early data that we've extracted over this time suggests that any modification of the classic duodenal switch, whether again you call it the SIPS, the SADI, or the modified or DS that we've done, is similar to the classic duodenal switch in regards to weight loss. And although it's too early to discuss any recidivism, the maintenance of adequate nutrient levels seems to be apparent. Again, that can be evidenced through the slides that we just went through. This is a graphic representation of how you can see the trends with weight loss. Again, you see you have the total body weight loss percent, estimated body weight loss, and their BMI reduction over time. And again, you'll see that at 36 months, it starts to level out. Again, this is just the body going into its survival mode and saying, this is what I feel comfortable at. Again, within the first 18-month period, you see significant weight loss, and then it starts to level off with time. I'm sure a lot of you guys are here to see what we do at Lenox Hill as far as post-op supplementation. And as I mentioned, the ASMBS came out with guidelines in 2008, which were then basically updated about a month ago. So a lot of what's written in there is trying to have all bariatric patients on a multivitamin, multi-mineral supplementation. They're high potent, so we want them to get about 200% of the daily value. And again, being a dietitian and with a lot of the education that I've gotten, I believe that a lot of our vitamins should be coming from food and diet. But what we use the vitamins for, again, is what I call health insurance. So just in case the patients aren't getting enough food because of the restriction of their smaller stomach, having a supplement taken on the side can help keep their levels normal. We have our patients start on a chewable or liquid form, and then after about 4 to 6 weeks, we have them progress to a capsule or a tablet as tolerated. It's important to remember that in the beginning phase of surgery, the patients have a lot of inflammation and a lot of swelling, so they may not be able to tolerate anything larger than a Tic Tac or an M&M. So we have them crush their vitamins or, again, go to a bariatric formulated vitamin. I can't say that I'm brand loyal to any one vitamin. I've seen significant, results with all different types of vitamins. Again, I live in New York City. We have a lot of patients on Medicare and Medicaid, so to have them go and purchase some vitamins may be a little costly. So whatever they can find at their pharmacy, again, I just keep a tight regulation on and have them do their blood work often. At our institution, we have our patients do vitamins preoperatively, and we just started that just to compare what their results are with the modified duodenal switch in the long term. And they need to do their blood work every 6 months after surgery. So again, all of these things, all the recommendations I'll be going over can change with time depending on the individual patient. We have our patients avoid time-released and enteric-coated tablets, again, because of the shorter common channel and the malabsorptive component of the intestinal tract. So it's important to really emphasize that. When I talk about having a complete multivitamin, we're speaking of something that has 18 milligrams of iron. Some of them, again, depending on how deficient they are or their history of anemia, or if they're menstruating women, may need a little bit more. So they may need to go up to 100 milligrams of iron. Again, looking for something that has folic acid in it, 400 micrograms to be exact, and something that, again, has selenium and zinc. I don't know about you, but I have a lot of my patients that come in asking about gummy vitamins, and I don't really endorse those because a lot of these gummy vitamins, number one, are made from high fructose corn syrup, which I try to have them avoid for, again, regulating their blood sugars and preventing weight regain over time. But most importantly, a lot of these gummy vitamins are not complete. In order to make a multivitamin, there are lots of ingredients that go into this that may alter the taste and or may even affect the gelatinous properties that a gummy bear gives. So a lot of these gummy multivitamins are lacking in thiamine specifically. So it's really important to explain that to the patient. The chewable forms, although may be chalky and may have a little bit of an aftertaste, may be better absorbed and, again, have higher quality of the 200% multi-minerals that we're looking for. Again, when we talk about complete, it's important that they find one, avoid any children formulas that are incomplete. So you got to teach your patients how to read these labels. Just the other day, I had a patient who said they're taking their multivitamins and the A, D, and K as we suggested, but they fail to read the serving size on their bottles. So some of them think that one pill just has everything, and it's really important to teach them to read that maybe it may take 2 to 3 pills to equate to the serving sizes that we're talking about. A lot of multivitamins, again, because they contain fat-soluble A, D, E, and K, need to be taken with food because they're absorbed better with foods, being that they're fat-soluble. And I know this can sound a little tough for the patients to do, but we have them separate their doses because there are some interactions with specific vitamins and minerals, such as calcium and iron. These need to be, they compete for absorption, so we have our patients take these 2 hours apart. Again, separating doses. Calcium, we know, can only be absorbed at 500 milligrams at a time, so although we tell them to take about 1,000 milligrams of calcium, again, these need to be separated throughout the day. With the modified duodenal switch, these are the recommendations that we have at Lenox Hill Hospital. As I mentioned, I am not brand loyal, but there is a great formula that Bariatric Advantage came up with for the modified duodenal switch, and it's called the multi-advanced EA vitamin. And the next slide, I'm just going to go flip back and forth. As you can see, it has 200% of the recommended values for vitamin A. It's pretty high on vitamin D, vitamin E, as well as thiamine, which we see as a common deficiency with bariatric procedures. The vitamin B12 is pretty high. The only caveat, as you can see that I highlighted in red, is the calcium. At Lenox Hill, we recommend our patients to get about 1,000 to 1,500 milligrams of calcium a day. Here you only see 150 milligrams, so we do suggest that our patients take a separate calcium in addition to the 2 pills of the multi-advanced EA that is all listed here. And again, keep in mind all of the percent daily values that you see here are with 2 pills as opposed to 1. So it's really important when you're going over labs and vitamins with your patients to see exactly what they're doing and how they're dosing them. Besides the Bariatric Advantage Multi-Advanced EA, again, I mentioned that we have our patients taking about 500 milligrams of calcium citrate 2 to 3 times a day. Again, this is all dependent on their levels, and again, this is to help with their, to prevent metabolic bone disease and their PTH levels. Calcium citrate is better absorbed than calcium carbonate because of the stomach acid, so it's better absorbed on an empty stomach. The next vitamin, again, depending on if they're getting enough from the multi, may be iron. It's, you know, I've learned from speaking with my patients, a lot of them who've experienced anemia or have taken iron in the past stop it. They don't comply well with it because they're usually taking ferrous sulfate, and that tends to be a little bit harsh on the stomach. I know it's a little bit easier to find at your pharmacy, and it's a lot cheaper, but I do suggest that they take ferrous gluconate or ferrous fumarate. I've seen great results with it. I've seen improvements in iron levels. I've seen better compliance because there's less side effects. And again, you just want to reiterate, or when you're going over iron recommendations, that you go over the type of iron that they're taking. We also know that iron is better absorbed on an empty stomach, as well as with vitamin C. So some of these iron supplements come with vitamin C in it. Otherwise, it may benefit the patient to take a separate vitamin C as well. Vitamin D, again, is a very, very common deficiency that I see mostly in African American females. But again, depending if they are going for a malabsorptive procedure, such as the modified duodenal switch or even with the gastric bypass, we have our patients on about 5,000 units, and we can go up to 50,000 units of ergocalciferol, which is the vitamin D2. Patients can be taking about 1 to 2 times a week. This can also be shown in their PTH levels. If their parathyroid hormone is significantly high, I try to review, again, how much vitamin D are you taking as well. And again, although they, if you just tell the patients that you need to take vitamin D, they might think, well, I'm taking it with my calcium, but usually vitamin D is found in only 800 international units in a calcium supplement. So taking a separate vitamin D on top of that may be beneficial. B12. So I have to say that and I'd love to hear what other people have experienced, but I have not seen too many B12 deficiencies. We do have our patients on B12, 1,000 micrograms 1 time a week, and this, again, is very easy for them to take because it comes in a sublingual form, it comes in a liquid form. There's some that even come in nasal spray, and a lot of them even go for intramuscular injections just to keep their energy levels up. So I still have yet to see too many people with B12 deficiencies. Zinc, again, it does come in a lot of multivitamins, but sometimes with my modified duodenal switch patients, I can see some zinc deficiencies. So we do suggest that they supplement, again, if they're low, with an additional 50 to 100 milligrams of zinc. And it's important to, again, take copper with that because that can also be reduced with low zinc levels. Vitamin A, I actually even see low vitamin A in a lot of my gastric sleeve patients. So I think this also helps with understanding that having the malabsorptive component with the duodenal switch doesn't only affect vitamin A levels, but any procedure where hydrochloric acid may be diminished or limited capacity for food may be affected. Vitamin A levels might be compromised, whether, again, it's a malabsorptive or just restrictive or both. So some of my patients, if they're not getting enough vitamin A in their multivitamin, need to be taking about 10,000 to 50,000 international units of a separate retinol. But again, it's important to ask the patient, are you taking a multivitamin? Because if they are not taking a multivitamin, that is probably why their vitamin A levels may be low. And you also want to make sure that they're getting in enough protein because protein and vitamin A work together. I rarely see any vitamin K deficiencies, and it's important that if you are supplementing with vitamin K that you are cautious with any coagulants that the patients are taking. And I am a huge advocate for brain food. If your patient is not eating enough of omega-3s from their diet from fish, it's great for them to start taking an omega-3 essential fatty acid with DHA and other essential fatty acids. This vitamin, the fish oil can also affect their bowel movements, so it's one thing that they should be supplementing always. And if they ever complain about the fishy taste or the fishy odor, I actually have my patients freeze these caplets, and then it's easier to swallow and doesn't repeat on them. So that fishy breath that they talk about can be alleviated. And there's also lots of products on the market now that come in a liquid form or a flavored gel. So those can be advised as well. This is the post-op diet that we recommend for our modified duodenal switch patients. We have our patients on clear liquids for the first day after surgery. We suggest water, hint water, smart water, decaf tea, sugar-free beverages, as well as sugar-free Jell-O. A lot of my patients complain of this rough feeling when they're drinking water. So, I've noticed that Smart Water by Glassow and Hint Water go down a little bit easier. So you may want to suggest having vapor distilled varieties of water as opposed to spring water if, again, they're complaining about hydration. From day 2 to day 14, so for the first 2 weeks, we have our patients on protein shakes. I'm a huge advocate, and we'll go over in the next couple of slides of how I counsel our patients to try and keep their sugars less than 10 grams per serving of anything that they eat, because I do believe that anything high in sugar can actually stimulate their appetite and get them back to those sweet cravings. So if they're looking for a protein shake, you want to make sure that it's less than 10 grams of sugar. If they don't like the taste of protein shakes, because a lot of them can be made with stevia nowadays, which can leave a little bit of a bitter aftertaste, or if they don't like sugar alternatives, they may go and make their own protein shake by using Greek yogurt and blending that with ice and maybe a fruit. So that can be part of that full liquid phase. Homemade soups, again, mostly bean-based, blended are appropriate. And with time, maybe by the 10th day, if I'm speaking to the patient and they're not having any problems with the foods or the liquids above, we can progress them to low-fat Greek yogurt, nut butters, hummus, and guacamole. Again, I like to encourage low-fat products as opposed to fat-free, because I do believe that fat is has a satiating mechanism, and foods that are usually fat-free tend to leave our patients a little hungry. On the 3rd week, they're moving on to thin puree foods that roll off the back of a spoon, such as blended tuna, soft scrambled egg, chopped liver, cottage cheese, pureed beans, mashed veggie burgers, silken tofu. I know sometimes when I'm looking at other institutions, they have applesauce on here and mashed potatoes. I like to really push protein. Again, our patients are limited with the capacity of food that they can tolerate. So if we're emphasizing protein needs, they should be resorting to a lot of the foods that you see here that are a paste consistency before they swallow. And as they progress to the 4th and the 5th week, they're moving on to thicker pureed foods, chicken salad, flaky fish, cauliflower mash, so they can get a little bit of fiber in, and any cold cuts if they chew it really well. This is when we're really emphasizing chew, 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 chew. Because I don't know about you, but a lot of my patients like to inhale their food, and some of them just put the spoon in their mouth and swallow. So this is the time where they really need to change their eating habits. With the modified duodenal switch, there is this fear of protein energy malnutrition. So again, because they're limited with the amount of food that they can eat, we try and emphasize 40 to 60 grams within the first 2 weeks, and eventually moving on to about 80 to 120 grams of protein a day in the long term. And I'm not very, very strict with serving sizes. I just want my patients to learn how to eat when you're hungry and how to stop when you're full. So although I give them guidelines with serving sizes, I can't say that I am very adamant about specific servings. As we all know, protein is important for wound healing. It helps keep our patients full. It prevents protein energy malnutrition. It helps preserve muscle mass, and it keeps the muscles metabolically active, which in the long run affect their weight loss efforts. So we try and have our patients follow about 1.1 to 1.2 grams of protein per kilogram. And we've seen them being able to do this when they focus on eating protein as their main source of nutrition. Changes in the beginning. So some of our patients report significant changes in their taste palette after having the modified duodenal switch. Some foods that may have been their favorites before are not desired as much. Cravings will develop for foods that they probably never enjoyed before surgery. So again, these are some things that you want to be aware of. And of course, the sense of smell may also be significantly heightened. They may feel a little bit nauseous with some foods. So that's when I'll push for foods to be a little bit cold rather than warm, and it actually will help with their feedings. Some side effects with the modified duodenal switch include SIBO, which is small intestinal bacterial overgrowth, frequent bowel movements, excess gas, frothing, and hair loss. SIBO, some of the symptoms that we see with SIBO are the same that you'd see for irritable bowel syndrome, such as nausea, vomiting, bloating, malnutrition, weight loss, some joint pain, fatigue, rashes, eczema. And this is a new topic in the GI world. I hope that you guys can do a little bit more research on it, because it does have to really involve the microflora in the digestive tract and the colon and in the small intestines, and how that affects gas buildup. And with the gas buildup, we see that it pushes back into the ileum and creates some methane or hydrogen gases. And the effects of hydrogen causes diarrhea, and the buildup of methane causes constipation. So we do know that the foods we eat can affect our symptoms. And we are going to see this a little bit more in anything that is altering a normal digestive tract. So what do we do to treat that? We have our patients, sometimes we may need to have them go on an antibiotic, maybe sometimes suggest chlorophyll tablets or specific vegetables. If they're complaining of gas odor, Devron or any bismuth subgallate can help them. They can also try some anti-foaming agents for gas to reduce bloating, such as simethicone, food enzymes such as galactosidase, and specific foods such as tomato juice, parsley, buttermilk, spinach, cranberry, or orange juice have been some more holistic approaches to treating gas, odor, and diarrhea. And one of my favorites, again, I'm a huge advocate for probiotics. I do believe in keeping hormonal, or I should say bacterial harmony with probiotics. So Culturel is one that they could easily find at any pharmacy over the counter, and VSL is also a very popular one, but it does come in prescription form. Other forms of natural probiotics can be found in kefir, Greek yogurts, kimchi, kombucha, but it's important to also advise the patients to read any labels of the kombucha that they may be drinking, because some of them can have some added sugars to it to increase its palatability. To prevent bloating and cramping, again, I mentioned that we have them on antibiotics, and there's some other herbal supplements that you can see here, peppermint oil, ginger tea, and herbal extracts. I'm not going to go into too much detail on the slide just because we're pressed for a little bit of time, but this is one product. It's called Iberogas, and what it does contain, again, is caraway, peppermint oil, and lots of natural forms of herbs and plants that help reduce gas formation and actually reduce gut inflammation by calming or soothing the gut muscles. So these are some things you can find online or, again, take separately. To treat hair loss, it's very common within the first 3 to 6 months in any weight loss phase, whether it's with bariatric surgery or again, with natural weight loss methods of exercise or just diet alone. So you have to tell your patients it's not directly impacted from the surgery, but just, again, from the weight loss in the short term. So anyone who is still losing hair more than 6 months may be dietary and nutrition related. So it's important to look at their zinc levels, their prealbumin levels, their vitamin A, B6, folate, essential fatty acids, iron, and biotin levels. I've also recommended Nioxin shampoo, and just this past weekend I learned that there's another shampoo out there called keratinase that might also help with thinning hair. And just reassure the patients that the hair cycle takes 3 to 6 months, so it's very common for them to lose hair, but it will come back. They just need to keep, again, an eye on their protein intake and the vitamins that we've listed here. This is a questionnaire that I sent out to all of my modified duodenal switch patients. I think this is so important because, again, I work with our patients very closely after surgery and also in the long term. And I wanted to know, how many times are they going to the bathroom, and what can they eat on a typical day, and do they regret surgery, and how has it changed their life? What vitamins they're taking, what changes they've made since they had the duodenal switch, how much weight they've lost, are they exercising, what type of exercise they're doing, a typical day of eating, do they get gassy, bloated, constipated, or diarrhea with any specific foods? Because, again, when I did a lot of my research on the duodenal switch, the classic one, I came across all of these symptoms that patients experience. And when I went on to blogs and, again, wanted to learn about the duodenal switch and wanted to know why my surgeon is doing it with all these negative side effects, I learned that by lengthening the common channel to 3 meters, which is what we do in this surgery, a lot of these things that patients complain about in the classic DS are alleviated. And these are the answers that I've gotten from 2 patients, so you can look at them. You'll see that a lot of them lose a significant amount of weight loss. This patient's bowel movements are 4 times a day, and when you look at her diet, again, she's having a lot of simple carbohydrates, and when you have a lot of simple carbohydrates, those are going to affect your the water levels in your body and your glycogen stores, so they're going to be going to the bathroom more frequently. She's also having dairy from milk and from cheese, and that's a pro-inflammatory food, which and also high in lactose, which can affect her bowel movements. And I suggested that she add some leafy greens for chlorophyll, and since then she has been feeling better. One of my star patients has only bowel movements twice a day, and that's exactly what we're looking for. This would be a little bit more normal with my experience of patients who've had the MDS. He's taking the Bariatric Advantage Multi-Advanced EA. He's taking an additional 5,000 units of vitamin D, a little bit more zinc. He's taking iron 3 times a day, and again, all my patients that are keeping the weight off have to be exercising. My background is in fitness and exercise, so I get them, again, really focusing on strength training activity because that's what's really going to keep their weight off. Some rules for lifetime success. You can see here it's a lot of the same things that we tell any other patient. It's also really important that we emphasize the 6 pillars to health. It's not all about just physical. They need a balance between social, intellectual, spiritual, emotional, mental, and occupational health for this physical to work in their favor. So it's really, again, I said that we're therapists, not just dietitians. These are a few of the commandments of eating, which are things that I emphasize when it comes to patients changing their eating behaviors, of reading food labels. And again, the most important thing that I really emphasize is that everything they eat, sugar is less than 10 and fiber greater than 3, so they are limiting their empty calories. No matter what surgery you're going for, you can still cheat. And with the modified duodenal switch, if you're going to be eating the crackers and the cookies and the simple carbohydrates, they will experience weight regain and they will experience a lot of the negative side effects that we were speaking about that come from the gas, the odor, and the bloating. Again, I try to teach my patients that not all calories are created equal. Although I don't have them calorie counting every single day, I try to have them on a very consistent eating plan. And I have them track their calories and just make sure that most of their calories are coming from protein sources. And I know I'm a little bit limited with time, but it's really important that we emphasize metabolism and how their metabolism is affected. Again, when they lose a lot of weight, they're slowing down their metabolism. So we really want to make sure that we keep their resting metabolic rate elevated by having them exercise, eating the right foods, and changing, again, their lean muscle mass. And this is one of my favorite quotes: if we were meant to stay in one place, we'd have roots instead of feet, by Rachel Walkin. And that really, again, goes back to having our patients move as often as possible. You know, when it comes to cardio or weightlifting, I believe in both, okay? Walking on a treadmill is great, but you really need to increase your lean muscle mass by resistance training. And there's definitely benefits to that, as you can see here, lowering their cholesterol levels, insulin sensitivity, and again, their sugar levels. And if they're still exercising but not losing weight, they're probably compensating by eating more or overestimating their caloric expenditure. So you really need to sit with a patient and go through, again, a lot of different things. It's not just about their food, it's about their behavior, it's about their you know, stress levels and how they manage their daily life. And you really want to dive into details when it comes to their weight loss and side effects. And what we do know is that many patients have nutritional deficiencies pre-op that can be exacerbated by malabsorptive procedures. But the restrictive procedures can also lead to nutritional deficiencies if they're eating the wrong foods and not tolerating specific foods, and again, restricting themselves to specific foods. So I can't say that I've seen one surgery work better than another, but again, with the weight loss and the concern of malnutrition with the modified duodenal switch, we've seen some great results. And strict nutritional supplementation postoperatively is going to be required for any malabsorptive procedure. So we have to keep that in mind. And most importantly, although we are trying to have our patients lose weight, we really, really want to encourage that they're coming to surgery to just regain control over their health. Losing weight is not the same as gaining your health. And I really try to have our patients understand that I'm not applauding them when they lose 40 pounds in the first 6 weeks. I'm really applauding them for their nutrition knowledge and just practicing all of the, the skills that we've encouraged them to participate in. So I thank you all for joining me in this webinar. And if there's any questions, please let me know.
Wonderful. So the first question came from Katie. What are some of the names of the multivitamins that you encourage your patients to take beyond just that Bariatric Advantage Multi-Advanced EA?
So there are lots of bariatric multivitamins out there. There's the Bariatric Fusion. There is Celebrate Vitamins. There is again, even if they're doing a Centrum chewable, as long as their levels are within normal limits, those are the ones that I probably encourage on my handouts. But again, as I said, I'm not brand loyal, so it's really what the patient has access to and what they can financially afford. But when they go to tablets, I the Solgar, Solgar multivitamins are a great vitamin as well.
Wonderful. Thank you. The next question comes from Dr. Bauman, and he said the modified version, as you know, is not approved by insurance in many states. How much of the info you're presenting is fair to apply to the conventional switch?
So we were doing some classic DSs before modifying it, and I do know that insurance does not always approve it, but the way that we have been again, coding is something that our surgical coordinators can be well versed in. I can say with my classic duodenal switch patients, I sometimes see a little bit more of lower levels of vitamin A, maybe their iron levels may be a little bit more compromised. So they're taking a few, again, and this is, again, I'm seeing patients who are mostly 2 to 3 years out. I don't know what's going to happen 7 years after the modified duodenal switch, but they're definitely taking a lot less pills. I've read on a lot of boards that patients with the classic DS are taking up to 20 vitamins a day. With our modified DS, our patients are only taking about, again, maybe 2 of the bariatric advanced multi-EA, separate calcium, and maybe a separate iron. And again, that's just with my experience.
Wonderful. The next question is there any reason to believe iron deficiency anemia should be expected more with the switch than with the bypass?
So I think with the longer common channel, with the data that we've gotten over time, I can't say that it's more common or more significant with the modified duodenal switch. The levels have improved with time, and that's with, again, our patients taking supplementation. So again, maybe 2 to 3 times a day, but it is definitely not anything worse than the gastric bypass.
The next question is, do you believe protein is absorbed in the colon?
So as far as I have been educated, it seems, again, from the nutrition and dietetics, I have to say that a lot of what I've believed and has been taught is that it is mostly absorbed in the intestinal tract of the small bowel.
The next question comes from Pamela. Is there any routine testing done for patient monitoring?
So we recently just started doing pre-op testing. We have our patients doing a comprehensive metabolic panel. We're looking at their iron levels. We're looking at their cholesterol levels. We're looking at their fat-soluble vitamins A, D. We just started looking at K, and we have not been doing E, I believe, because it's a little bit costly. So this is something that I brought to our surgeon's attention because I'd like to really compare pre-op and post-op specifically for our modified DS patients. And of course, hemoglobin A1C.
The next question is, what testing is done to determine overgrowth of bacteria and the need for antibiotics?
So a lot of these tests can be done at a gastroenterologist's office. They can do the hydrogen breath tests, and that can help, again, understand a little bit more of any intolerance that patients are experiencing. The need for antibiotics, I think it's a case-by-case basis on how doctors usually treat these issues. Being a dietitian, I'm going to go first to natural forms of supplements, and there is no data that supports, from a lot of the research that I did over time, that antibiotics have long-term treatment. Again, I think it's mostly for the short term.
Our next question is, what are your recommendations to meet essential fatty acid requirements in relation to food, not just a supplement, and do you test for it?
We actually don't test for it. And when I presented this talk 2 weeks ago live for surgeons during the Modified Duodenal Switch course, there was one surgeon that actually came up to me and said that I think he practices in West Palm Beach. They actually started testing for fatty acids. We do not do it here at Lenox Hill. It was something that I did bring to my surgeon's attention after speaking with the surgeon that I met in Florida. And he said that he recommends a specific pill that patients are taking 2 to 3 times a day. But as far as patients getting it from food, I'm a huge advocate of patients trying to get as much seafood as they can, at least 2 to 3 times a week. And it's also high in protein, so that's a double whammy.
Is B12 given 1,000 mcgs every week in shot IM form or once a month?
Again, if I'm counseling the patients, I'm telling them to take 1,000 micrograms every week orally. If they're getting it intramuscularly, they're usually seeing their PCP for that, and it's something that they've been doing prior to their surgery, and then they just continue doing after. I haven't seen anything where my patients are too low in B12. If anything, it's more common that I see my patients' B12 levels being higher than necessary.
Sharon, we can't thank you enough. This has been an invaluable hour of everyone's time. And for everyone on the line, again, we are so pleased to have each of you here. We, again, are committed to this bariatric space and continuing to provide educational webinars. So in the future, please continue to connect with your Ethicon reps, because I am in the process of building a few additional webinars that will be coming out in 2017. And then additionally, Sharon is available if your representative would like to work with their education specialist if you have any follow-up questions in relationship to today's webinar. But again, thank you all very much, and I hope you each have a wonderful day. Thank you, Sharon.
Thank you.